And also to the next session. So to chair this session, I call upon senior pediatrician Dr. Tanapan sir. So sir does not need any introduction. Sir is a very senior and very active, very famous pediatrician who was instrumental behind the KONGU PEDICON, which was conducted last year. So we welcome you, sir. And we invite the next speaker, Dr. Johnny Sebastian. Sir is a national EB member. He's a consultant pediatrician, the Health Service Department, Government of Kerala. He's a chairperson of Allergy and Immunology chapter, IAP Kerala. He's the president of NNF Thalassery, secretary of IAP Kerala, and sir has many more credits. So over to you, sir.
Thank you all. Very good afternoon to all of you. At the outset, let me thank team KONGU PEDICON for giving me this opportunity to present this very common topic before this August audience. So for the next 20 minutes, I'll be rushing through updates on bronchiolitis, and I'm sure that all of you come across bronchiolitis quite often. And bronchiolitis, as we all know, it can be very challenging for the pediatricians, since it can become quite serious, as well as if we don't have a specific treatment other than supportive care. So it is a mild self-limiting disease, as well as it can be a very potential case needing admission, as well as maybe ventilation also. So bronchiolitis is a common respiratory problem of infancy and young children. Bronchiolitis affects more than 1/3 of children in the first 2 years of life and is the most common cause of admission to the hospital in their first year. As we all know, bronchiolitis is a lower respiratory tract infection preceded by a simple URI and characterized by obstruction of small airways, causing acute inflammation, edema, and necrosis of the epithelial cells lining small airways, as well as increased mucus production. In fact, the whole small bronchioles are filled up with mucus. The most common causes are RSV virus. It can also be caused by rhinovirus, adenovirus, influenza, human metapneumovirus, parainfluenza, bocavirus. Co-infection with multiple viruses and bacteria can also occur in 10 to 30% of young hospitalized children. Mycoplasma is mostly found in older children with bronchiolitis. So this is a very important slide which gives you an idea how this bronchiolitis progresses day-wise. As you can see, the severity and bronchiolitis peaks at around day 4 to day 6, and then it slowly settles down. The signs and symptoms like rhinorrhea, with or without fever, you can see in the first 2 days, and from day 2 to day 10, the infants can have persistent cough, increased work of breathing, retractions, abdominal muscle involvement, rales or wheezes, or both together, and impaired feeding. From day 10 onwards till day 20, you can have a gradual resolution of symptoms with continued variability. The new fever late in course might suggest a new co-infection also. After, if you are seeing after 14 days, a sudden exacerbation or a sudden fever, you have to always suspect a co-infection like otitis media or pneumonia or a new virus along with this primary organism. So in pathophysiology, the upper respiratory tract It includes that from day 1 to day 4, you have virus infecting the epithelial cells and which are sloughed to the lower respiratory tract, but the lower respiratory tract is invariably normal in the first 5 days. And from the 5th day onwards till the 18 days, you can have the involvement of the lower respiratory tract. So the further epithelial infection with edema, sloughing of cells into airway, mucus production, and edema with associated obstruction and air trapping. Ciliary function is impaired. Polymorphonuclear cells and lymphocytes proliferate into the area in an inflammatory response. And gradually, while settling down, from day 16 onwards, you have upper and lower respiratory regeneration of the epithelium. So this slide gives an idea of how bronchiolitis progresses in an infant. Symptoms of bronchiolitis can be very minor ones, like a blocked or runny nose the first few days, a dry cough, a slight high rise of temperature. All these are the common cases which comes to your OPD practice. A rasping or persistent dry cough, rapid or noisy breathing or wheezing, brief pauses in breathing, feeding less and having fewer wet nappies, vomiting after feeding and being irritable. Diagnosis. So diagnosis is a clinical diagnosis basically. You don't need any investigations. So it is based on age, seasonal occurrence, typical clinical presentation and physical examination. Blood investigations and radiology is routinely not indicated. Only it is if needed, if in case of admission, or if you don't want to misuse antibiotics as part of AMR and all, you can do the investigation. Overlap between virus-induced wheezing and acute viral-triggered asthma. The severity of bronchiolitis is classified into mild, moderate and severe. So the feeding ability in mild cases is normal, respiratory distress is little or no respiratory distress at all, and saturation is always more than 92%. In moderate cases, a shortness of breath appears during feeding, moderate distress with some chest wall retractions and nasal flaring, saturation is less than 92%, correctable with oxygen. In severe cases, the baby or the infant may be reluctant or unable to feed, severe distress with marked chest wall retractions, nasal flaring and grunting, can have frequent and prolonged apnea also. Saturation is less than 92%, which may or may not be correctable with oxygen. So even if you are trying to correct with oxygen, it may not be correctable in severe cases. So such cases definitely requires admission. The investigations in admitted patients to rule out alternate diagnosis like bacterial pneumonia, congenital heart disease with failure and sepsis. Admitted babies may need ABG, CBC, CRP, serum electrolytes and chest radiograph. And if you are going for identification of viral agents, you can go for PCR or culture of respiratory secretions obtained by nasal wash or aspirate. The new techniques, real-time PCR, nested PCR and multiplex PCR can also be used. The home management, most children get better with care at home. There should be only symptomatic relief that, that consists of hydration, proper hydration, monitoring the breathing, and you have to clear the airway, like giving some saline nasal drops and all to open up the airway. So you should have maintained the hydration. Fever should be controlled by the paracetamol, and child should be made to lie in a propped up or head and elevated position. That is to relieve that nasal distress. The proper use of bulb syringe, as we all know. So, and it should be kept for that baby itself, and it should be properly cleaned also. So the red flag signs are the increased work of breathing If you see an increased work of breathing in a case of bronchiolitis, grunting, nasal flaring and chest retraction, decreased fluid intake or decreased activity, as well as any altered sensorium, all those things are red flag signs. You have to act immediately, because as the time lapses, the child may go in for need of ventilation. So viral bronchiolitis can be classified into mild, moderate and severe, as I have already explained. And the mild one does not need investigation and only home treatment is required. The moderate one, you have to give humidified oxygen to keep SpO2 more than 92 to 95, IV fluids, or we can try an hypertonic saline trial, observe for deterioration, always the respiratory rate. And you have to teach, even if you are sending the baby home, you have to definitely take time to teach the mother about the red flag signs, as well as to look at the breathing, monitor how to monitor the breathing or count the breaths. In severe cases, you need definitely admission, ICU care. Oxygen, again, you have to keep it high, and IV fluids, cardiorespiratory monitor, ABG, chest X-ray, and assess if needed for ventilation. If there is improvement, you can decrease the oxygen guided with SpO2 monitoring, re-establish feeding, discharge when the baby is feeding well and the distress is less. And not single reading, you have to repeat after some 30 minutes for number of times, and only once the infant is stable you have to discharge. Deterioration, you have to again treat as severe bronchiolitis. So hospitalization, coming to hospitalization, only a small % of children require hospitalization. Persistent tachypnea, more than 60 breaths per minute. Respiratory distress in the form of grunting or recessions, inadequate oral intake, inability to feed, dehydration and inadequate fluid intake. Then if there is a hypoxemia, of course, state of the patient, altered sensorium, etc., they all need hospitalization. So predictors of severe bronchiolitis. Some of the predictors of severe bronchiolitis you can predict even when the child comes to the for your first visit in OPD. Like host related risk factors are prematurity, especially less than 32 weeks of gestation, low birth weight, less than 6 to 12 weeks, that is newborns, chronic lung diseases including BPD, hemodynamically significant CHD, immunodeficiency, or any infants having neuromuscular disorders. Among the environmental risk factors, if the child is having older siblings, of course they are carrying that URI or something, there are chances that younger infant can have this bronchiolitis. Then passive smoking, household crowding, child care attendance, and lower socioeconomic status. In the clinical predictors, you have toxic or ill appearance, oxygen saturation is less than 95%, respiratory rate more than 70 breaths per minute, moderate to severe retraction, and atelectasis you can see on chest radiograph, whitewashed. So you have to have a patient-centered care. We have to discuss with the parents, and absence of effective therapies. 30 to 70% of family members also are ill in such cases. Restriction of visitors to newborns during the respiratory virus season, October, November, and parental education is helpful in the promotion of judicious use of antibiotics, as we are all now giving less and less antibiotics. As we all know, we are crusaders of antimicrobial resistance program. And the intensive care, as I have already told, and the mainstay of treatment nowadays is heated, humidified, high flow nasal cannula, or continuous positive air pressure in case of admissions, to reduce the work of breathing, improve gas exchange, avoid endotracheal intubation in children with bronchiolitis who are at risk for progression to respiratory failure. So if you start it earlier, we can reduce the cost. Adverse effects of endotracheal intubation, like a laryngeal injury or a ventilator induced lung injury or a ventilator associated pneumonia, etc. can be avoided. So HFNC, as we all know, permits high inspired glass flow of 4 to 8 liters with or without increased oxygen concentrations. Flow rates of more than 6 liters per minute can generate positive expiratory pressures in the range of 2 to 5 centimeter H2O. The size of nasal cannula, which is determined by the fit, affects the size of the circuit. Better tolerated and anybody can use that who is not in a resource limited hospital or institution. So reduce the use of sedation like in ventilated babies, duration of ICU stay, duration of hospitalization, and also hospital associated infections. So contraindications to HFNC are abnormalities of the face or airway that prelude an appropriate fitting nasal cannula, confusion or agitation, and highlight the importance of early initiation. That is very important. The complications, you have abdominal distension, aspiration, pneumothorax, which is rare. In a meta-analysis of 2 trials comparing HFNC and CPAP, the risk of adverse events was lower with HFNC than CPAP. So clinically deteriorating with significant respiratory acidosis, you have to go for endotracheal intubation, and apnea may require endotracheal intubation and mechanical ventilation. Poor responsiveness to stimulation, weak or no cry. Arterial or venous blood gases obtained in infants with impending respiratory failure with hypercapnia. So weaning off, as we all know, we have to wean off slowly. 2/3 of infants had at least 1 episode of SpO2 less than 90% for at least 1 minute. Half had at least 3 episodes. Some had SpO2 less than 90% continuously for more than 3 minutes. So episodes of desaturation typically occur during sleep or while feeding. So no role of chest physiotherapy, antibiotics, montelukast, ipratropium, systemic or inhaled steroids, steam inhalation, and all those things. And of course the palivizumab or nirsevimab, they all have no role in acute management but useful in prophylaxis. So immune prophylaxis with palivizumab monoclonal antibody was the mainstay of treatment, but in 2025 the new thing has come, nirsevimab is there, and that molecule you can give only a single dose just before the RSV infection period, that is the October and November, whereas the palivizumab you have to give at least 4 to 5 doses every monthly injections, and palivizumab was costing around 15,000 to 20,000, whereas nirsevimab is costing around 45,000. So that vaccine is marketed by Sanofi, and that is now available in India also in the brand name Beyfortis. So, so all infants who are suspecting any high risk of developing a severe bronchiolitis, we can use it less than 5 kg. You give 50 mg of the vaccine, that is 0.5 ml, and more than 5 kg we use 100 mg, that is 1 ml of the vaccine. In the first RSV season, before the first RSV season, they are facing in their life. So if the baby is having other complications like or other comorbidities like CHD and all, you can give it in the after that for 1 year also. Then you have to give 2 doses of 100 mg nirsevimab. So it is both 0.5 ml as well as 1 ml. They are costing between 40 and 45,000 per dose. And recently the gynec has also come with that they can give babies to be delivered within 2 weeks, that is after 36 weeks, and babies which are going to be delivered within 2 weeks, they can be also be given nirsevimab as a maternal vaccination so that you can prevent bronchiolitis. So the complications are acute respiratory distress syndrome, myocarditis, congestive heart failure, arrhythmias, bronchiolitis obliterans, secondary bacterial infection, as well as predisposition to childhood asthma. The discharge criteria, as we told, respiratory rate is less than 60 per minute, less than 6 months, 55 in 6 to 11, and 45 above 12 months. Caretaker knows how to clear the infant's airway using bulb suctioning, stable for at least 12 hours prior to discharge. Patient has adequate oral intake to prevent dehydration, because that is very important. Hydration is very important. Caretakers are confident they can provide care at home and they can easily come back. If they are at a very remote place, you can keep them for a longer time. Avoidance of smoke exposure and timely receipt of routine childhood immunizations. Primary and secondary prevention, hand hygiene, minimize passive exposure to cigarette smoke. Just 1 minute. Avoiding contact with individuals. Immunoprophylaxis can be done with monoclonal antibody, as I told, and annual influenza immunization is recommended. So coming to this thing, that take-home message is infants and children with moderate to severe respiratory distress usually require hospitalization. Non-severe bronchiolitis usually can be managed in outpatient setting unless there are concerned about the caregiver's ability. Oral intake sufficient to prevent the dehydration, no need of IV fluids, but if the child is taking well orally, and education of the caregiver. The simple steps are: wash your hands regularly with soap and water, keep infected children at home until their symptoms have improved, keep newborn babies away from people with colds or flu, wash or wipe toys regularly, keep your little one away from tobacco smoke. Thank you so much.
Thank you, sir, for the excellent talk.
Hello. Thank you very much. Dr. Sebastian, you can come and sit here, please. Beautiful talk. Day-to-day affair we meet, that is bronchiolitis. So, any questions? So, I want to ask you one question. That is, when we were students, we were told that give humidified oxygen. Another thing, give by a hood. Is it still continuing or not?
So actually, sir, the delivery by hood is not sufficient enough to prevent the collapse of the lower airways. So that is why we are using HFNC these days. Thank you.
Any more questions from the floors, please? So I think, so one question. One line. Come to the front, please. The mic goes up.
Sir, my question is role of bronchodilators in bronchiolitis. You said ipratropium is not of use. So sometimes first episode of Weezer may present as bronchiolitis. There may be a wheeze. It may be the first episode of wheeze. So in that case, can we use bronchodilators or not?
Yes.
In future, it may turn into a Weezer also.
That is a good question. You can give a trial of bronchodilators, but as such in bronchiolitis, it is not proven. But it can, you have to rule out both. So in that case, you can always give a trial of bronchodilators.
Thank you.
Thank you.
Feeding of the children with the bronchiolitis, moderate to severe cases, because in practical, if we see when you attempt to feed the baby, either the direct breastfeeding, that itself aggravates tachypnea. How to take this?
So in moderate to severe bronchiolitis, it is better not to attempt for feeding, direct breastfeeding. Either you can give express breast milk so that the nasal block is not severe. and also the effort is less from the baby's side. And in severe bronchiolitis, of course, we have to go for IV fluids.
Thank you, sir. I now invite our next speaker, Dr. Prashant Kumar Sabod, Professor of Pediatrics at IMS and SCO Medical College, Bhubaneswar, and Vice President of Central IAP E-Zone 2025. With expertise in infectious disease, immunization, and adolescent health, he has led several IAP initiatives, including OPSIS under the Presidential Action Plan 2024, and has numerous national and international publications to his credit. Over to you, sir.
First of all, let me express my gratefulness to the organizers who has given me the opportunity to speak here, and with permission of the chairperson and all seniors, let me start. So today the topic is on mother to child transmission prevention from vertical transmission to viral suppression. So when we, 10 years back, when we were reading, it was that only we were giving ART to mothers and Nevirapine to the children. But it was not very, very clear that how long we will give, when we will do the screening test for the baby receiving ART, whether we'll give lifelong or not. Then there were the medications also were coming in different strips. So now with strong NACO and WHO guidelines, our country has also come out with very good plans, very good strategy. Though it was launched in 2002, but only for the last decade, it has come to the action. So we all of us know this, that the vertical transmission chances, if in pregnancy is 5 to 10%, if the mother is HIV positive, during delivery, it is 10 to 20%, and during breastfeeding, it is around 5 to 20%. So these are the probability of transmission of HIV from mother to child, if the mother is HIV positive. In our country, this rate was more than 40% in 2010, and the progress is now that in 21, it is around 12.95 at 6 weeks, but the final was more than 20%, it's 24.25%. In India, every year there are around 29 million pregnancies. Out of that, 35,000 they are HIV positive. This is the data by NACO in 2015. In 2021, there was a study which shows that 5,000 new vertical infections are happening every year, added to the already existing pregnancies, existing mothers. But the good thing is that there is significant improvement due to the universal ART and PMTCT programs in the country, and you will be very happy to know that Tamil Nadu is showing the better performance compared to the national average. So in Tamil Nadu, you can see the mother to child transmission at 6 weeks is 5.29%. Our target, the SDG target is to reduce it to below 5%. So Tamil Nadu is having 5.29%, whereas our country, it is national average is 24%. And in Tamil Nadu, final MTCT rate is, if they calculate within that 6 week also, so it is 8.86%. It reflects the effective state level interventions. So we have seen the oration, we have heard the oration of Indumati madam. So that commitment level of Tamil Nadu is definitely, that is an exemplary. So it must be in every programs. So India's target is to reduce it to less than 5%, and this vertical transmission, we can check it at every level, but now the strategy is mainly on testing and giving the drugs regularly. So this PMTCT specifically was launched in 2002, and significant ART scale-up for pregnant women was also integrated with MCS services. And now in our country, there are 20,756 ICTC centers, but now they are planning to involve the private hospitals as well as they are also taking to sub-district level of subdivision hospital and even to CHCs. Wherever there is a pregnancy, they are trying to, government is trying to establish these ICTC centers. With effect from 2014, all pregnant women who are HIV positive, this is a big and a very bold step taken as per the guideline of WHO, that if a mother is HIV positive, irrespective of CD4 count and WHO clinical staging, she will be taking ART throughout her life, even after delivery also. And every 6 to 8 months, there will be testing for the viral load in the body of the mother. And newborns to be initiated on 6 weeks of nevirapine immediately after delivery if the mother is HIV positive. And it should be given at least for 6 weeks. But if the mother has not taken anti-ART for 24 weeks during the pregnancy period, so that in that case it will be extended. So the guideline is that in the first trimester itself, HIV need to be diagnosed and ART should be started immediately in the case of HIV positive mother. So if it is less than 24 weeks, then the nevirapine will be given for 12 weeks of life to the newborn. And mother will continue her ART. The HIV exposed baby will be given Cotrime prophylaxis at 6 weeks after this dose is over, nevirapine, and will be baseline HIV DNA PCR will be done at 6 weeks. If positive, then it will be done twice, so that to confirm it. And then it will be repeated at 6 months of age, then at the age of 1 year, and at the age of 18 months. So for this prevention, the universal precautions, all of us are aware that safe delivery practices to be done, infant prophylaxis to be given. WHO recommends for low-income countries and middle-income countries exclusive breastfeeding, even the mother is, if the mother is even the HIV positive. But the option can be given to the mother that if they can afford, then they can go for tin food, but it should be exclusive. There should not be mixed feeding. The recommendation is mixed feeding is dangerous. Either it should be exclusive breastfeeding or it should be exclusively tin food. So in order to provide universal access, so now it has come down, the facilities have come down to the CHCs as well as to the PHCs and also to the private practice. So this is about the viral load. We were talking that every 6 months it need to be repeated, whether the viral load, how good is the viral load, and if it is reduced. So now the recommendation is for triple therapy. So 3 antiviral drugs are given in one combined pack is given, so that the mother do not miss her daily dose. And of course, for the baby, the growth, development, and adherence, it should be there. Monitoring is very, very important. So for this viral suppression, the goal is undetectable viral load. So viral load, the goal is that it should become so that it will reduce your horizontal and vertical transmission, both it will reduce, and definitely it will improve the survival rate. It will reduce the resistance, drug resistance, and improves the quality of life. It also prevents the opportunistic infection. So what are the challenges? The challenges are still, in our country, if you go to rural area or the urban poor population, the registration of pregnancy itself happens in the 4th month of pregnancy or 5th month of pregnancy. They report to the ANM or the health worker at 4 to 5 months. So a lot of time is, lost. Along with that, there are these natural calamities of, this flood and, war zone and conflict zones and other things, where we are not able to access to those, our target group. So that also results in the late diagnosis. Drug formulation palatability is definitely, earlier when the tablets were separately given, so there were a lot of resistance, and the patient also, that we know, compliance, our experience in TB drug, in nephrotic syndrome. So we have seen the drug compliance is a big issue, and the sir was taking this asthma case. The patient will come, what is the problem? That they are diagnosed, they have been even very well explained how to take, when to take, but they will not take and they will land up in emergency. So this adherence difficulty is one big challenge in pediatric patient, not in HIV, in everywhere. And stigma and disclosure issue, definitely this stigma is a big challenge for us, because still the society is not able to accept in many parts, but gradually we are fighting it out. And the long-term care is to continue the ART. So in continuous ART means the supply should be also good, the support of the government should be also good, it should be available in proper quantity. Monitoring of the ART by the health worker, whether they are taking every day or not, and in case of no supply, they need to have the alternate source. Along with that, there should be monitoring of the viral load. So every 6 months, the patient, the child and the mother, they need to go to these ICTC centers for monitoring the viral load. Nutritional support, definitely it is very important. So that is also a big challenge, that nutrition support to be provided at the doorstep. The challenge is to provide a doorstep, and as per our reason, there are the mothers, the women, they will take the, whatever the nutrition support also goes, that goes to the distributed in the family, rather than only to be consumed by the mother and the child. And then psychosocial counseling, this is also lacking in the rural areas, because we have these counselors, it is a big challenge to get counselors for these rural areas. And transition of adult HIV care. So transition to adult HIV care. So when the child grows to adult, so he's, that transition period also we need to handle it, so the child follow up for continuous this testing and adherence to the drug. That is very, very important. So in this fight to reduce and to get our target of 2030 SDG, so the way forward is that to enhance ART coverage and adherence to the drugs by all, improve access in rural and underserved areas, to use digitalization, digital tools for monitoring mother-baby pairs. This is a very important thing, that now the ANMs are also given these mobile phone, Android phones, so that there are apps so that they can monitor it, and if the mother is also having, they are monitoring it on a daily basis and monthly basis. Then community engagement to reduce the stigma. So to involve the community leaders, the village influencers, to reduce the stigma due to the HIV in the community. That is one important aspect of to reduce and eliminate. So the elimination target is to reduce 5% vertical transmission by 2024, which we have already missed. So now they have make a target, the date is 2030. So by 2030, they want to, we want to reduce this to less than 5%. Along with that, we want to reduce it to such a level that it should not appear as a public health problem, rather than it will be confined to the clinical care and as in the hospital-based settings. So thanks for your patience listening. Any questions, I will be happy to take.
Beautiful presentation by Dr. Sabath. Thank you very much. Nice enlightening talk. Any questions from the floor, please? Thambi?
So my question is, by 6 weeks, if the child becomes positive by DNA, we have to repeat at 6 months. When to start ART?
Immediately after birth.
So nevirapine we are giving, the triple therapy when we have to start?
For the baby?
For the baby.
For the baby, it is the recommendations now is to give a prophylaxis of cotrime till 18 months and then till 5 years if it comes positive.
We are not
That is the
going
guide.
to
We are not giving triple therapy. Triple therapy is mother.
Mother.
Thank you, sir.
what will be the life expectancy of the child if the child is HIV positive?
Sir, now, you know, there are HIV positive children who are taking antiviral. They are in the age group of 45-50. So, and they are also having children, healthy children. So, the expectation is as per the normal only. There is only thing is they need to take care of, you know, infection prevention practices like all those things, sir. So, people living with HIV AIDS also, no, there is a big community now. They are more smarter than us because they get all facilities, everything. Yeah, sir.
Any more questions, please? Thank you, sir. Thank you very much. Thank you very much.
Thank you, dear chairperson and speakers. I now request our chairperson, Dr. Thanappan, to present mementos to our speakers, Dr. Johnny Sebastian, and to Dr. Prashant Kumar Sabot. Thank you, sir. Thank you for the excellent talk. Thank you, sir. I now request Dr. Johnny Sebastian to present a memento to our chairperson, Dr. Thanappan, as a token of appreciation. Thank you, sir. Thank you, chairperson and speakers. Dear delegates, an important announcement. We will not be having a separate lunch break as we are already running 45 minutes late. So lunch is already served, so you can go for lunch in between sessions and the sessions will be continued simultaneously. Thank you. So our next speaker, our next speaker is Dr. Sri Sailam Kuturu. Sir is from Ganga Saraswati Children's Hospital, Nizamabad. He is the president of NNF Telangana 2025, a national executive board member of Central IAP, and director of the IAP CPR Center. With expertise in neonatal and pediatric resuscitation, adolescent nutrition, and Sattvic health practices, he has been a prominent academic leader and trainer across India. Over to you, sir. It's an honor to have you here.
Yeah. Good afternoon, everybody. First of all, at the outset, I would like to thank the organizing team and my mentor, President Singaruveli sir, and also Rajendran for giving this opportunity. And today's talk is on the first 1,000 days of life. Now, the neonatal code, cracking the first 1,000 days of life. And we all know what's the first 1,000 days of life I mean. That's 270 in utero and 365 in the first year and 365 in the next. That sums up to 1,000 days. You know, we often talk about saving lives, but today let's talk about shaping lives, shaping the futures by understanding and decoding what really happens in the first 1,000 days of life. Now, what if I told you that a lifetime of health and intelligence and resilience is shaped before your child's second birthday? Yes, the critical window of opportunity is the first 1,000 days of life. Now, why the first 1,000 day really matters? A child's brain undergoes very rapid growth, and imagine the formation of the neurons, the connections, 1 million neuron connections every second, and by the age of 2 it's 80%, and by the age of 5 the brain is 90% of the adult size. So it forms an important foundation for the cognitive potential. Let me tell, apart from the rapid neurodevelopment, it also has a blueprint for the lifelong health trajectories, be it the metabolic, the epigenetic program, because we are all gifted with the genes, but expression of the genes is influenced by the epigenetics, that is above the genes. We often blame for any undue things that happen in our life contributed by the genetics. But is it really justified to blame only genes for that? Definitely not. Because it's only the genes can explain only up to 20%, while the epigenetics, it's about 80%. When I say epigenetics, it's the environment, it's the temperature, it is the physical activity, the exercise, the nutrition, the infections, they all contribute and they can change. Now when I tell about epigenetics, I should mention about the methylation, Why? Because the genes are there, only the expression is hampered with the methyl group, which is been acting like a sticker and makes the gene expression silent. So the epigenetics is very important. And in the first 1,000 days, the immune system foundation also is taking place. So it's very important that the first 1,000 days, it is the foundation for not only the growth of the brain, the development of the brain, the immunity, the skills, the cognitive functions, all these are happening right in this 1,000 days of life. The slide I think is not complete, but let me tell you, global and the national data, what it speaks about. Around 149 million children are stunted globally. And my heart really aches when I say that India is the stunting capital of the world. Yes, 36% of the entire, in the world, India is contributing, and 34% underweight children. So, so there's always a burden for India, and the triple burden of infections, malnutrition, the growth problem, all these are part of this, the neurodevelopmental delays. So this triple burden we have to tackle at the earliest. Now, when I showed the data slide here, what does it mean? It's not that the issue is large, but it is very urgent that we have to act fast. The basic code for the neonatal code is what we can do as pediatrician, because we are the stakeholders of the health of the children. So our contribution in this 1,000 days is very important. And the idea that there is a biological blueprint we can influence through early interventions. So the crux is that early interventions by identifying early. And think of this decoding of a clinical triad. We are talking about 3 domains. One is the growth, another one is the immunity, the third is the neurodevelopment. This can't be looked at as isolated ones. They are interdependent. For example, the growth of a child is, there is a faltering because of the nutrition, suppose. And whenever there is a imbalance, inadequate nutrition, it just doesn't affect the growth alone. These micronutrients deficiencies, they can have an effect on the immunity. So a child who is underweight or malnourished will definitely is more prone and susceptible to infections too. So his immunity is affected. So when the gut is not healthy, it's not able to absorb, definitely the child will have a deficiency of micronutrients, for example, iron. And deficiency of iron again affects the neurodevelopment. So when we talk about these 3 domains, they are not dependent, They are not they are interdependent. So what I mean to say that it should be looked whenever a child of malnutrition or immunity, we should think in these three domains. Can you make it full screen? Yeah. Achha, it's not coming. I don't know, no video. Okay, fine. No, but the maternal health is very important. And we know that the fetal programming, it starts right in the utero. And modern science has woken up to this 7,000-year-old or ancient wisdom of Garbha Upanishad, where we talked about Garbha Sanskara. And we know that the fetus is being fed, not only the nutrition is received from the umbilical, through umbilicus, it is, we are shaping and molding their brains too. And we have very good examples of, from the Abhimanyu, from Mahabharata, where in utero he could learn the Chakravyuham. And we have heard about Prahalada story also. So all this, what does it mean? That the nurturing is happening right in utero. So if you look at the Barker hypothesis, where he has seen in England that in the areas where the mothers are subjected to starvations, children when they grow with adequate nutrition, there is a high tendency of these children to develop obesity, diabetes, so which he labeled it as a fetal origin of adult diseases. So there are good, ample amount of examples to say that it is the foundation is laid right in utero. And let me talk about the brain development. Now if you look at the stages of the brain development, you see in the newborn, the neuronal cells, and at 1 month, almost a little bit different, numbers might be different. But what strikingly changes by the time 9 months and 2 years is these connections. So the nerve cells are same, but the connections have increased. And when it goes to adult, it is lesser. That is what is the pruning what we talk about. So synaptogenesis is, I said in the beginning, that 1 million neuronal connections are happening every second. I think even the Ambanis can't compete, 1,000 Ambanis, to have the number of connections that are happening. And pruning is very important because as the brain gets sophisticated, the unwanted or the unused ones get replaced, they're eliminated. So the looking at the synaptogenesis around, by the age of 2 years, the number of synapses per neuron is approximately 15,000 synapses. But as it grows to adult and adolescent age group, it's less by over 50%. So the brain development, whatever is, it's maximum during this period. So looking at the organogenesis, from a bilaminar zygote, we have then embryo that happens in the first 2 weeks. So by the age of 6 to 8 weeks, majority of the organs are formed. So first day of missed period is already day 14th of post-conception. And by all the organs, as I said, are formed by 9 weeks. Now why I wanted to stress upon this slide is, if a pregnant woman, and majority, more than 50% of the women, their pregnancies are unintended, majority of them, they are not aware of that they are pregnant. Only when they become amenorrhea at 2 months, they might approach for pregnancy test. So what really happens, 2 months of amenorrhea is almost 8 to 10 weeks. So majority of the organs which are forming, make full slide. So when you talk about duration, why I'm talking about this importance is, if they talk about care of the pregnancy, the duration of pregnancy, it's not 9 months, because I said, even the early ANC cannot prevent some of the defects of organs. So it should be 3 months added to that. It's 12 months, which is the pre-conception care. So before the pregnancy itself, this. Next slide. So we all, in this August gathering, I think we all, even if we make a poll, 100% would answer that yes, the breast milk is the best, and from birth to 6 months, there is no other feed except breast milk. And it is the complete food, and it's the nature's own food, what you can call it. So the breastfeeding is very important for the development of the baby, not only as a nutrition, but for the development and bonding. So if we talk about the complementary feeds that has to be given from 6 months, we have to stress upon the fact that still there is a confusion where they say that 6 months means 5th month they cross, some of them consider it 6 months, and 7th month by the time it's already 1 month late, some of them consider it 6 months. So the message should go clear, it's 180 days. So that I think part. And regarding the type of food, it is not just the quantity, the quality of the food that is very important, the variety and the nutrient rich food, that's very important. And the regular monitoring of the growth is very important in the OPD. And we should focus that from 6 to 2 years of age, prioritize foods that are rich in micronutrients like iron, vitamin A, zinc, and choline. These are all important brain nutrients that are very important for the development of the growth. And we have ample amount of tools to do the monitoring for the growth, be it the IAP growth charts, the WHO charts, the Z scores. All these are important. The only thing is that we have to put them into use. So the immunity can be, when a child is born, is vulnerable to multiple infections, but what can prevent is a good kangaroo mother crate, exclusive breastfeeding, avoiding the prelactal feeds, and the microbial priming can be done with breast milk, and the gut improves, and delayed cord clamping. All this really help for. So again, breast milk is the best, the nutritional foundation that happens during in utero, and building immunity is important, and the vaccines timely, and no child should miss any vaccine, and the opportunity whenever he comes to the clinic should be taken first priority to give him the vaccine. So adequate nutrition, prevention of the recurrent infections, good sanitation, hygiene, all these are important to prevent growth faltering. And mother, as I said, and her health is very, very important, as it's the foundation for the babies. So as a caregivers, what role we have? Yes, we have to teach them that responsive caring is very important. And it has been seen that those children nurtured in orphanages, babies, just 3 more slides, okay? The size of the brain is less, the connections are less, it really has a great devastating role. So parenting is very important, and caregivers are very, very important. Love, affection, touch, hug, and understanding and responsive caregiving is very important. So the key takeaways, I would like the first 1000 days represent a once in a lifetime opportunity, and the brain development, the emotional health and physical, they all happen during this period. The key actions that we should include is provide the breastfeeding exclusive up to 6 months, and minimum of breastfeeding to 2 years of age, providing rich stimulation by responsive caregiving, and it's crucial to avoid toxic stress, because any stress, the cortisol has a effect on the neuro development, and encourage movement, play through early childhood that fosters the cognitive skills. Avoid toxic stress and screen time, and pregnant mother should not be argued, and you should not disturb her, cause stress. And we used to say that it is better not to fight or argue with a pregnant woman because it has effect on the fetus. And though she might be wrong, better avoid arguing with them. And you don't need any fancy tools. Only thing is that what we require is just love, care and affection. So empower every caregiver in your respective centers, be it PHC or any urban health centers and your clinics, that the knowledge and support are very important. The nursing staff, their burnout has to be considered, and train them. The forgetfulness curve is always there. So train the nursing staff to use the growth chart. It makes your work very easy. So if we change the beginning of the story, we change the story. So the first 1,000 days of life are very, very important. Thank you. Sorry for overshooting. Okay.
Thank you, sir, for your enlightening talk. Our next speaker is Dr. Karthik Annamalai, who is an MD pediatrician, consultant pediatrician in Coimbatore Children's Healthcare. He specializes in pediatric vaccination, immunology, pediatric nutrition, growth and development. He's won the Active Pediatrician Award by IAP in 2023. He's served as a secretary of Coimbatore IAP from 2016 to 2018, and he's a state EB member. We welcome you, sir.
Yeah, thank you. So good afternoon, everyone. So you all would agree with me, almost 10-15 years back when we all started our practice, it was just PCV 7 first, and then we had two pneumococcal vaccines, PCV 13 and PCV 10. Then came one more PCV 10, and now we have PCV 14, we have PCV 15, we have many other companies coming with PCV 13 and 14. Recently we also have PCV 20. So are all the vaccines same? And which PCV do we choose, and how do we decide on the pneumococcal conjugate vaccine that we are going to use? This is what I'm going to talk about. I'll keep it very short. So the talk of the town is Coolie. So we just have a Coolie remake with a little bit of role reversal. So Coolie has one hero and many villains. Here we have one villain, pneumococcus, and we have many heroes. We have PCV 13, PCV 10, PCV 14, and the latest PCV 20. So just a word about PCV 20 here itself. So from this last week onwards, PCV 20 is very much available everywhere. So current recommendation for PCV 20 in India, see globally it came long back, and it is being used for children in the US and all other countries as per the regular vaccination schedule. As per PCV 13, PCV 20 is also given in the same schedule. In India, PCV 20 is still not yet licensed for use in children. Studies are going on, very soon we'll be getting the approval. So as of now, it is licensed for use in adults. So the guidelines for adults are above 50 years, you give a single dose of PCV 20. Initially for PCV 13, we used to say give a single dose of PCV 13, and then you give PPSV 23. And then every 5 years you keep giving PPSV 23, especially for immunocompromised adults. But now it is only one dose of PCV 20, and you're done with it. You need not give PPSV 23 later. If the adult had previously received PCV 13, you can give one more dose of PCV 20 now. Even if they have received a dose of PPSV 23 and PCV 13 also, you have to give them another dose of PCV 20. So that is about PCV 20, the latest. So about the serotypes. So we all know that the pneumococci has a capsule which is formed by the polysaccharide chains. So this is the capsule, and these are the polysaccharide chains. So the distinct polysaccharide structures of the capsule form the basis of classification by serotype. So it's classified based on this serotype. And the polysaccharides, this coiled spring-like thing is the polysaccharide. They have the specific chemical structure and are antibodies that are targeted in the vaccines will actually bind to the polysaccharides and then boost the immune response. Now, we all know polysaccharide vaccines are not that immunogenic, and conjugating polysaccharide vaccines to a conjugate like CRM or like TT can induce a robust antibody response and improve the immunogenicity of the vaccine. And one more thing that you should all remember is antibody for one serotype will not recognize another serotype. So it is specific. So there are over 100 serotypes, but their role in disease is not equal. So we had PCV7 and then PCV13 was added. And these are the vaccines that are presently, PCV13 covers all these serotypes, which we are all familiar with by now. So what is the current PCV landscape in India? So as we were talking about the villains and the heroes, so see, the villain is different from area to area, from city to city. So the vaccine that we give, our hero should know the local serotype, the strengths of the villain should be known by the hero. So we have Pfizer's PCV13, which has CRM197 as the carrier. And then we have the old and new PCV10, PCV14, which has excluded 6A and has included 22F and 33F. And then we have PCV13 with TT as the carrier. And now PCV20 also is added to this. So are all these conjugate vaccines the same? Are they equal? Are they similar? Or are they different? So there are three headings under which we should see them. The serotypes. So we'll forget about the older PCV10, mainly of the newer PCV10. It lacks 3, 4 and 18C. And both of them lack serotype 3. PCV14 lacks 6A. And even regarding the composition, it's not just the serotype. And with serotype also, please remember that higher the number doesn't mean the immunogenicity is better. Just the number and the valency are totally different. So antigen concentration of each individual serotype is also very important, and that is higher in PCV13. And antigen concentration for majority of serotypes for PCV13 is higher than that of the older PCV10 also. And conjugation technology is important, and the carrier is also important. So as I told you, TT and CRM are the major carriers. So with TT, what can happen is we also use the other vaccines, the DPT vaccines and the hexavalent vaccines, which have TT as the carrier. So when you keep on giving using TT as the carrier, the antibodies will start targeting the carrier also. So this is called as carrier-induced epitope suppression, CIES. So because of this carrier-induced epitope suppression, carriers with CRM1 is much preferable compared to the TT carriers. So what are the prevailing myths? So this is the commonest myth. Serotype 6B provides adequate cross protection against serotype 6A. Is it true? No. Our IAP also very clearly says direct protection is any day better than cross protection. So it is like the hero saying, I cannot punch the villain, but I can punch the villain's cousin. No, you have to target the villain. So direct protection any day is better than the indirect protection or cross protection. So the next couple of slides are just going to highlight this, and we know 6A can cause serious disease, it can cause invasive pneumococcal disease also. So this is just to keep highlighting that 6A is important, and direct protection is way, way, way better than cross protection. So this is the purple book from IAP, which very clearly says direct protection rendered by serotype included in a vaccine formulation is definitely superior to any cross protection offered by the unrated serotypes, even of the same group, in any PCV formulation. So IAP is very clear in this. So the next serotype, the next myth, serotype 22F and 33F are more important than serotype 6A. Is it? So here again, a lot of studies which says that in India especially, existing evidence suggests that the proportion of IPD attributed to serotypes 22F and 33F is relatively low. So yeah, they are the villains, but they're not the main villains, they're the side villains. So they are important, but in our country, in India, they're not that important. So based on the pneumococcal surveillance data available, what is the estimated coverage of pneumococcal conjugate vaccines? You can see that the coverage is much better, and with PCV 10 and 13, and after the government has started taking up PCV vaccines, the burden of pneumonia has definitely come down. So are all PCV vaccines the same? So we're going to see about, I think I spoke about this, the Pfizer PCV13 and the other PCV13 which is available. The carrier is again different, CRM versus the TT. Okay, so the Pfizer PCV13 versus other PCVs, they are approved for different indications, and PCV13 by Pfizer is the only vaccine that is approved for all ages. Even after 5 years, even less than 5 years can be given. And to highlight this point again, CRM 197 when used as a carrier protein prevents the reductive amination, and activation, derivation, conjugation techniques are also different. And this is the carrier-induced epitope suppression that I was talking about. So the peptide from carrier acts to anchor the sugar epitope to the MHC cells and allows the presentation of the sugar epitope to polysaccharide specific T cell also. So carrier-induced epitope suppression is common with other PCV13, especially when TT is used as the carrier. CRM 197 has very little of carrier-induced epitope suppression, and the effectiveness and the immunogenicity hence improves. So the OPA analysis comparing the PCV13 versus the CRM 197 versus the TT also, you can see that the immunogenicity and the OPA profile is definitely better with CRM 197 as the carrier. So there are 3 important criteria which for a WHO pre-qualified vaccine. It should meet the WHO standard for vaccine quality, safety and efficacy standards as endorsed by the WHO expert committee. And it should be suitable for the target population, and it should meet the operational specifications for packaging and presentation. So CRM 197 has received WHO pre-qualification, whereas the one with TT has not. So PCV13, one more thing that the next common myth is saying that invasive pneumococcal disease prevention is what is important, and nasopharyngeal carriage or reduction in otitis media is not that important. It is not true, especially in a country like India, where we have the more than the invasive pneumococcal disease, we have a burden of non-invasive pneumococcal disease, especially otitis media, nasopharyngeal carriage. So eradicating that also, including nasopharyngeal carriage, is definitely very important. So serotype 3, is it an atypical serotype? It is said that serotype 3 is an atypical serotype, and none of the PCVs provide effectiveness against serotype 3. So agreed, serotype 3 is a strong villain, is a villain with a bulletproof coat, but it is not that difficult to eradicate. So PCV, other vaccines which targeted serotype 3 have been effective, and there has been a definite reduction in the number of invasive pneumococcal disease cases following introduction of vaccination in several countries. So though it is a difficult serotype to eradicate or to fight against, it is not that no vaccine or no antibody will work against it. There are vaccines which can target the PCV3 serotype also. So it is not, and yeah, serotype 4 and 18C are said to be clinically non-significant and not important for Indian babies. Here again, no, serotype 4 and 18C are like old villains. They are like Nambiar and Emarada. So they are still, they can come back, and they can come back with a bang. So just because they are not prevalent now doesn't mean they are completely eradicated. After successful vaccination, the number of cases are relatively low, but it is still being reported. And they can cause invasive pneumococcal disease, including meningitis, bacteremia, and bacteremic pneumonia also. And now the next myth is that an ideal PCV should provide protection against IPD only. No, ideal PCV should reduce the nasopharyngeal carriage, should decrease otitis media, should also decrease non-invasive pneumococcal disease. Just skipping these for want of time. So there are proof from various countries showing that the number of cases of otitis media, nasopharyngeal carriage, and even non-invasive pneumococcal disease had drastically reduced after the introduction of PCV13. So reducing nasopharyngeal carriage is definitely a priority for pneumococcal vaccines. So catch-up vaccination and vaccination with PCV for high-risk and older children. We know the regular schedule, it's 6, 10, 14 weeks, and then the booster. So in case the child misses the dose, you can give 2 doses 8 weeks apart at a later age, and even if the child is seen after 2 years, even between 2 to 5 years, you can give a single dose of PCV13. So the key takeaways: fact 1, serotype 6A is responsible for 1/6 of the overall pneumococcal burden in the Indian population, and direct protection is definitely superior compared to cross protection. Existing evidence suggests that the proportion of IPD attributed to serotypes 22F and 33F is relatively low and is as less as 1.5% combinedly. Serotype 3 infection is associated with severe clinical manifestations, and PCV13 has been reported to reduce incidences of serotype 3 infections across many countries. 4 and 18C are outbreak serotypes and have been included in PCV7 itself, and they can come back. And pneumococcal infections can vary in incidence and severity, and PCV13 provides the comprehensive package control for all the serotypes. So choose wisely. I thank you. Thank the organizers for giving me the opportunity. Thank you.
Thank you, sir. Now I kindly request Senior Pediatrician Dr. Anand to please give away a token of appreciation to our speaker. I kindly request Dr. Karthik sir to please give a token of appreciation to Dr. Anand. Thank you, sir. Now kindly request Dr. Karthik sir to please give a token of appreciation to Dr. Anand. Thank you, sir.
I now invite Dr. Babu to chair the next session. Sir does not need any introduction. Sir is a senior pediatrician and an inspiration for all of us. I now invite Dr. R. Muthuvel to present his topic. Sir is a consultant pediatric intensivist at Ma Kaveri, Trichy. His areas of interest are fluids and electrolytes, toxicology, critical care neurology and nephrology, and ECMO. He is IAP-PCC accredited teacher, PALS trainer, and he's authored 3 original research papers, 3 book chapters, and multiple case reports.
Thank you.
Check. Okay, good afternoon everyone. At the outset, I thank the organizers for having given me this opportunity to chair this session. Hypertensive crises in children are uncommon but potentially fatal if not diagnosed early and treated. So we'll listen to what Dr. Muthuvel is going to guide us. Over to you, sir.
Thank you, sir. A very good afternoon to all, and I would like to thank the KONGU PEDICON team for inviting me to deliver the talk on hypertensive crisis management, causes and clues. And the next 20 minutes we are going to discuss about what are the definition and different terminologies used in hypertensive crisis, and what is the real problem with hypertensive crisis, why it is very important, and what are the morbidity and mortality associated with it, and what are the causes and clues to the etiologies, approach to diagnosis, and stepwise management of hypertensive emergency. Let's start with the definition. Hypertensive crisis is also called as accelerated hypertension or acute severe hypertension. So it's actually defined as per 2017 CPG guideline as a sudden and abrupt elevation in blood pressure from baseline, potentially leading to rapid end organ damage. So actually hypertensive crisis encompasses two entities. One is hypertensive urgency and another one is hypertensive emergency. And both are not an absolute terms, it is a spectrum. A child with hypertensive urgency, if you fail to treat, may progress to hypertensive emergency. So hypertensive urgency is nothing but blood pressure elevation is accompanied by minor or no symptoms of end organ damage, whereas hypertensive emergency is BP elevation accompanied by evidence of severe symptoms or signs of end organ damage. However, this definition is not complete because in this definition there is no absolute BP cutoff value. In children, what we do, we measure BP. So we should need an absolute BP cutoff value above which we can say the child is in hypertensive crisis. But when we look into the literature, there is a specific adult, there is a specific cutoff value for adult. That is BP more than 180/120 millimeter mercury is defined as hypertensive crisis in adults. But in children and adolescents, there is no clear-cut definition because the normal blood pressure itself varies with age. So when we look into the literature, there were several definitions were used before. Before the 2017 American Academy of Pediatrics clinical practice guidelines, that is BP above 99th centile or stage 2 hypertension or 20 millimeter mercury above 95th centile, or all can be classified as hypertensive crisis if associated with severe symptoms. However, in 2016, the European Society of Hypertension guidelines have given a cutoff of 20% above the stage 2 hypertension limit. So this we can take it as a cutoff for hypertensive crisis. However, in 2017, the clinical practice guideline clearly states that it doesn't define hypertensive crisis. It merely states that BP elevation well above stage 2 hypertension threshold can be classified as a hypertensive crisis. The clinician should be more concerned when the child BP increases more than 30 millimeter mercury above the 90th centile. So to finalize, and the patients may be diagnosed with severe hypertension based on a BP number, but the BP number should not be the only parameter which guides us to define hypertensive crisis. For example, some children may have high BP, for example, systolic 160, 180, and may be completely asymptomatic. An adolescent with a chronic kidney disease may be completely asymptomatic and sitting in OPD. When we check the BP may be 160 or 170. At the same time, the same amount of BP, 160, 170, may cause dramatic symptoms in some children. For example, a 10-year-old child presenting with acute glomerular nephritis, this 160, 170 BP can cause papilledema and vision loss. On the other hand, severe organ damage can also occur even with mildly elevated BP if the rise is very rapid. For example, a 7-year-old child with post-streptococcal glomerular nephritis, the BP may be just 130 or 90, but the child may be already having headache, dizziness, or hypertensive encephalopathy pictures. So we don't define the hypertensive crisis based on specific numerical cutoff. So ideally it should be individualized, that is how fast the BP has risen and what is the baseline BP and what are the patient-specific risk factors. So why it is important? Because pediatric hypertensive crisis is very rare. However, recently the incidence is rising because of increased BP screening in OPD and emergency and better survival with chronic kidney disease and congenitally corrected cardiac diseases. The incidence also, the reported incidence also varies widely because there is no definitive cutoff point. Some studies have reported the incidence is 0.1 to 0.6% in emergency settings, whereas some studies have reported the incidence is 15 to 54% also. At any given point in time, hypertensive emergency always overweighs urgency in pediatric ICU settings. That is around 60 to 70% of children with hypertensive crisis presents with end organ damage. Among those end organ, central nervous system is the most commonly involved organ, followed by renal and cardiac. Why it is important? Because a single episode of hypertensive crisis increases the risk of CKD progression and it can lead to persistent hypertension. It may also cause cognitive deficits and cardiovascular event. The mortality associated with hypertensive crisis is 4 to 6% in well-developed countries, even it is more in resource-limited settings. The mortality is often linked to late recognition of hypertensive crisis, intracranial bleed with massive stroke, or advanced CKD or heart failure at the time of diagnosis. So coming to the etiology of hypertensive crisis, in adult, the commonest etiology of hypertensive crisis is primary or essential hypertension. Whereas in children, the most common cause, around 3/4 of children, it is due to secondary causes. In young infants, neonates and younger children, the renal artery stenosis, congenital anomaly of kidney and urinary tract, and coarctation of aorta were the predominant causes for hypertensive crisis, whereas in older children, renal parenchymal diseases are the most common cause compared to renal artery stenosis. So other less common causes include endocrine disorders like pheochromocytoma and paraganglioma, drugs or toxin exposure like steroid intake, calcineurin inhibitor intake like tacrolimus intake, and sympathomimetic drugs intake, and some other rare causes are monogenic hypertension like primary hyperaldosteronism, congenital adrenal hyperplasia, like that. However, the incidence of primary hypertension is presently increasing because of rapid rise in the epidemic of obesity. So this is a study which shows that, which was done in PG Chandigarh, where they have, it's a retrospective study where they have enrolled 56 children presented with hypertensive crisis. The most common etiology, they find that renal etiology, 61% of renal etiology followed by pheochromocytoma, our 32% were of unproven etiology. So the clinical features of hypertensive crisis and the neurological are the most common symptom. The child can present with headache, dizziness, vomiting, or altered sensorium and seizure, followed by cardiovascular symptoms like chest pain, breathlessness, and symptoms of congestive cardiac failure. And visual symptoms like visual disturbances, retinal infarct, hemorrhage, and papilledema warrants urgent evaluation and management. And the renal symptoms can include hematuria, oliguria, proteinuria, and dyselectrolytemia. Whereas in neonates and infants, they won't present with typical CNS manifestations. They can present with irritability, feeding problem, failure to thrive, tachypnea, and lethargy and seizures. So coming to the history in hypertensive crisis, history taking is very important to narrow down the differential diagnosis. The onset and course itself can give us clue. If the symptoms are of acute in onset, that is acute severe headache and vomiting or seizure, may point towards acute secondary hypertension due to renal, endocrine, or CNS disorder. Whereas if the hypertensive crisis is gradual onset over a period of weeks, it indicates the child may be having chronic conditions like chronic kidney disease and chronic renal parenchymal disease. Evaluating previous BP record is also important, whether the child is having pre-existing hypertension or it is just a simply acute severe hypertension. And some of the cluster of symptoms like diarrhea, pallor, oliguria, and hypertension may point towards hemolytic uremic syndrome. Hematuria and oliguria may point towards glomerulonephritis and obstructive neuropathy, whereas hematuria and edema may point towards nephrotic and nephritic picture. Palpitation, episodic setting, and flushing points towards endocrine tumors like pheochromocytoma and paraganglioma. Usually this episodic hypertension is common in adults with pheochromocytoma. In children with pheochromocytoma, it will be more of persistent hypertension, not episodic one. And drug history, we should ask, is there any history of steroid intake, or as already said, calcineurin inhibitor intake, sympathomimetics, or illicit drugs like cocaine and amphetamine intake. And clonidine, abrupt withdrawal of clonidine and beta blocker can also cause withdrawal symptoms as present as hypertensive crisis. And positive family history may denote monogenic hypertensive causes, early cardiovascular disorders, and endocrine tumors. Coming to the examination point of view, the examination should be systematic and targeted. In general physical examination, we have to look for presence of short stature and webbed neck, which may point toward Turner syndrome. Dysmorphic faces may point towards some genetic syndrome related to hypertension. Cushingoid faces, presence of striae and central obesity may point towards capillate macules and point towards Cushing syndrome, whereas capillate spots, they point toward neurofibromatosis 1, which is commonly associated with renal artery stenosis. And vital examination, we should check blood pressure in all 4 limbs and we should palpate pulses in all 4 limbs. If the upper limb BP is more than lower limb, it may point towards coarctation of aorta. If there is a marked asymmetry between right and left, and right upper limb and left lower limb, it may point towards subclavian or renal artery stenosis secondary to vasculitis. And tachycardia could be due to catecholamine excess. Any child with hypertensive crisis with bradycardia, we should think of raised intracranial pressure. And cardiac examination and neurological examination may also give us a clue to narrow down the differential diagnosis. So how to evaluate when a child presents with hypertension crisis? So the evaluation, it is a three-pronged approach. The first one is we should look for identifiable causes from history and physical examination, which was already discussed earlier, and complete blood count can also give us a clue. The child may have anemia in case of chronic kidney disease. Thrombocytopenia will be there in case of hemolytic uremic syndrome. Thrombocytosis will be there in case of rheumatological condition like vasculitis. And leukocytosis may be there in sepsis-associated hypertension or chronic pyelonephritis. And measurement of renal parameters, renal function tests like blood urea nitrogen, creatinine, and serum electrolytes are important. And urine analysis and urine culture may give us a guide that the child may have chronic pyelonephritis secondary to vesicular-ureteric reflex. And renal ultrasonography is, should be done to rule out congenital anomalies of kidney and urinary tract, and serum cortisol renin level can be done to rule out endocrine cause of hypertension. So the next evaluation is we should evaluate for presence of comorbidities. Fasting lipid profile and fasting glucose will help us to identify metabolic syndrome, which commonly associated with essential hypertension. If there is a history suggestive of drug intake, we can go for urinary drug screen. And in case of obese adolescent presented with obstructive sleep apnea, we can do polysomnography. And the third important thing is we have to evaluate for presence of target organ damage. So target organ damage, the commonest is CNS. If the child presents with CNS symptoms, you can go for neuroimaging. Otherwise, routinely we have to do echocardiography and ECG, which can help us to identify whether the child is having LVH or not. Presence of LVH indicates the hypertension is chronic. If it is acute rise, the child may not be having LVH, the child may have dilated cardiomyopathy. And retinal examination to look for papilledema or hypertensive retinopathy changes. So additional investigations include renal Doppler ultrasonography and MRI and CT angiography to look for renovascular hypertension, and plasma urinary catecholamines can be checked if it is an episodic hypertension and if we are suspecting pheochromocytoma or paraganglioma. So coming to the management, so management of acute severe hypertension is similar to any sick child presenting to our emergency. The first important step is maintenance of airway and breathing, and the second important step is children with hypertensive crisis need continuous and frequent BP monitoring in ICU. So ideally, children with hypertensive urgency can be managed with frequent auscultatory and oscillometric measurement of BP, whereas children with hypertensive emergency should be admitted in ICU, and we should monitor the BP with intra-arterial BP monitoring, because it helps us to monitor the BP accurately, and if there is a early fluctuations in the BP during the course of treatment, it will help us to identify, and we can do sampling also in that port. So the site preferred is radial or femoral artery, and we should also think of complications like distal ischemia, vasospasm, and systemic infection while inserting arterial line. So then come to the next important topic is what antihypertensives to use in case of hypertensive crisis. The first is route of administration. In case of hypertensive urgency, there is a sufficient time. There is no end organ damage, so you can try oral medications. Whereas in hypertensive emergency, it should be always treated with IV drugs, preferably by continuous IV infusion. So what is the choice of antihypertensive? So if we look into the literature, there is no comparative prospective studies investigating what is the best class of antihypertensive medication used. It's a review of literature which shows that in the available pediatric literature, the most of the pediatric literature are of retrospective studies and retrospective case reports under of single center studies. There are no multi-center study which compared head to head which drug is better than other. And when we look at the practice, they commonly used beta blockers like metoprolol and labetalol, and calcium channel blockers like nifedipine and nicardipine and nitroprusside. So it is always depends on, since there is a no clear-cut guideline which antihypertensive to use, it should be based on physician preference and experience. What is the drug available in your scenario, and the drug cost, and the rapidity of action, how fast you want to reduce the PP, and the safety of the medication, and ease of use and ease of titration. And you have to also consider the underlying comorbidity. For example, a child with bilateral renal artery stenosis, you can't use AC inhibitor because it may worsen the acute kidney injury. Similarly, a child with congestive cardiac failure, you should avoid using beta blocker. A child presenting with hypertensive crisis and congestive cardiac failure, we can't use beta blockers. So you have to look into the underlying comorbidity also. And you have to choose a drug that targets the proposed pathophysiological process of BP elevation. For example, in a pheochromocytoma, the cause of hypertension is excessive catecholamine. It acts on both alpha receptors and beta receptors. Only if you know the pathophysiological process, you can use appropriate drug. So the first drug you have to use in pheochromocytoma is alpha blocker. If you use beta blocker as first, there will be excessive catecholamine. There is the unopposed alpha action, so the child may worsen. So in pheochromocytoma, first you have to use alpha blocker, then you have to use beta blocker. So when we look into the guideline, the European Society of Guidelines says sodium nitroprusside and labetalol are commonly used. They are not suggesting anything. They just says that when they look into the literature, they found that sodium nitroprusside and labetalol are commonly used for children with hypertensive crisis, whereas American Academy of Pediatrics suggests esmolol, labetalol, hydralazine, nicardipine and nitroprussides are commonly used in pediatric practice. So this table describes the commonly used antihypertensives in children with hypertensive crisis, and the most commonly used drugs are esmolol, labetalol, nicardipine and sodium nitroprusside. Esmolol, as I already said, it's a very rapidly acting and short acting beta blocker. It can drastically reduce the BP, but it should not be used in very caution in children with congestive cardiac failure. And labetalol is a combined alpha plus beta blocker. It is a good all-rounder. In most of the can be used in most of the condition, except again labetalol should not be used in heart failure or reactive airway disease. There are some retrospective studies which has compared labetalol with sodium nitroprusside, and they found that labetalol causes better reduction in blood pressure earlier, and children who received labetalol have better neurological recovery when compared to those received sodium nitroprusside. And nicardipine is a calcium channel blocker currently most commonly used. So it acts within minutes. Again, it should be used very cautiously in heart failure. It may cause significant thrombophlebitis. So when you use nicardipine, you have to use central venous access. And sodium nitroprusside, one of the age-old drug, which is very commonly used in practice, but nowadays it is less preferred because it, dose more than 8 mics per kg per minute, and prolonged infusion can cause cyanide toxicity, especially in the presence of renal dysfunction. But in children, the most common cause of hypertension itself is renal pathology. So we should use cautiously sodium nitroprusside in hypertensive crisis. So what is the role of oral antihypertensive in hypertensive crisis? The only indication for using oral drug in hypertensive crisis is hypertensive urgency, because you have sufficient time for the drug to get absorbed and to act. So the commonly used oral antihypertensives are clonidine, istradipine and nifedipine. If you see the adult guidelines strictly not recommend, they don't recommend to use nifedipine because nifedipine will cause drastic reduction in BP. However, retrospective studies in pediatric didn't show that. In pediatric, it was found that the nifedipine is mostly safe, but since no prospective studies are available, guidelines doesn't recommend nifedipine in pediatric also. So when you are using oral antihypertensive in hypertensive crisis, you have to monitor BP very frequently and try to use either clonidine or nifedipine. So what is the target BP in hypertensive crisis? So while managing hypertensive crisis, we should know, and at what point we should stop the IV infusion and switch to oral medication. So the target is less than 95th percentile in children with hypertension without end organ damage, whereas less than 90th percentile in children with end organ damage or secondary hypertension or children with underlying comorbid condition. Whereas in case of pheochromocytoma and paraganglioma, the target is less than 50th centile for age, sex and height. So again, the rate of BP lowering in hypertensive crisis, there is no experimental and clinical evidence. It is all based on retrospective studies. The one thing we have to remember in rate of BP lowering is slow reduction BP is the key. Whenever we manage hypertensive crisis, we should do gradual reduction in BP, and we have to achieve that target over a period of 24 to 48 hours. Since there is no definitive guidelines, we commonly follow this principle of quarters. That is, during the first initial 8 to 12 hours, we will reduce the BP not more than 25% of the target BP. In the next 12 hours, we expect further 25% reduction target BP. Over the next 24 hours, there occurs final 50% reduction. So over 24 to 48 hours, we will achieve the target BP. During that point of time, just 1 minute. During that point of time, if the BP drastically falls, when you are managing hypertensive crisis with IV antihypertensive, if the BP drastically falls, what you have to do? You have to temporarily stop that antihypertensive infusion. You can give a bolus of fluid, 5 to 10 ml per kg, or you can start low dose vasoactive. So this graph, I hope most of us during our residency would have done this practice when consultant told us to draw this graph. And this graph mainly helps us to monitor how gradually the BP is falling. So, for example, if the present map at the admission, the BP is 200 by 140 and the map is 160 millimeter of mercury. So the target map we expect is 120 millimeter of mercury. It has to be achieved at the end of, this is the 95th centile, it should be achieved at the end of 48 hours. So first 8 hours, we want only 10 millimeter of mercury reduction in the map. Over the next 24 to 48 hours, we want 50 millimeter of mercury reduction. Sorry, 30 millimeter of mercury reduction in the map. So the BP doesn't always fall as expected. So most of the time there will be fluctuations in the BP. Minor fluctuation, we don't need to worry. If there is a major fluctuation, if there is a rapid shoot up in BP, you have to increase the dose of antihypertensive. If there is a rapid fall, as I already said, you have to stop the antihypertensive and you have to try bolus or inotropes. So at the same time, we have to manage the underlying conditions also. For example, in coarctation of aorta, the definitive treatment is surgical correction. And in coarctation of aorta presenting with hypertensive crisis, you can try esmolol. Beta blockers is more preferred in coarctation of aorta. In case of renovascular hypertension, you can use AC inhibitors and beta blockers. Diuretics you can try in case of volume dependent hypertension. For example, children with post-streptococcal glomerulonephritis and nephritic and nephrotic syndrome, you can try diuretics. Pheochromocytoma and paraganglioma.
We are running short of time,
sorry.
so if you could just.
So to conclude, so hypertensive crisis, always first look for organ dysfunction. If present, treat as emergency. If absent, treat as urgency. So these are the take-home messages. Think always BP yearly. Just 1 minute. So measure BP in every sick child. Prevention is always better than cure. In your OPD practice also, as well as in emergency practice, always check BP for any child. Again, numbers are not enough. Hypertensive crisis is always defined by end organ damage, not just by digits. And 80% of the children has reversible etiology, so find out the cost fast. And rapid drop in BP can be as dangerous as high BP, so lower with care. And again, time is the organ. These are the references. Thank you.
Thank you, sir. The topic is very well covered. Please come over here. We'll have the questions towards the end of the session. Next, I invite respected Elizabeth, madam, most awaited topic. Over to you, madam.
Good afternoon. Thank you, Chairperson and team KONGU PEDICON for this excellent opportunity. So my topic is quite wide, medical nutrition therapy in selected conditions. In the available time, I am planning to cover 10 scenarios. The first and the foremost will be what you see is non-bilious regurgitations in a baby. And so the first thing is that, is there any failure to thrive? If there is failure to thrive, we have to go very aggressive. Otherwise, GERD, we manage conservatively. And another thing is that, is the child having any neurodevelopmental issue or central hypotonia? Then the GERD may continue even after 2 years. Otherwise, as age advances, they get over it. So what is most important will be, what we usually used to do is the prokinetics. Among the prokinetics, the cisapride, everything is now banned. So we are now using erythromycin, sometimes we use. And among the PPIs, we are using lansoprazole and esomeprazole. And very short period, we may be using ranitidine, etc. But mind you, some of these drugs have drug interactions and QT interval prolongation. So that is the thing. And very rarely, if it is very resistant and the child is having severe problem, failure to thrive, not getting corrected, surgical interventions also we do. And positioning and thickening of the feed, as you all know, is the thing. And for positioning, so we are recommending, we can go to the upholstery shop. I show them these pictures and ask them to make a 45-degree bed like this. Otherwise, you know, we tell them to elevate the head, but the child will be coming down and will be becoming supine after some time. And then the controversy, and this is very interesting, that is the straddle type of feeding, or this is also called Australian cola method. This method is very good. The baby is actually propped up. So the laid back type of feeding. So this is what I show them, they can practice. Then there is controversy as to whether it is the right lateral or the left lateral. I think when we were students, the old Cloherty said right lateral, and I copied it in my book also. But now there is evidence that the lateral is best. And prone position we are not nowadays recommending because of increased SIDS, sudden infant death syndrome. And actually, this also, from the upholstery shop, we can get this type of bed specially designed for the child. And they say that the right lateral versus left lateral, the left lateral is now said to be better because the lower esophageal sphincter's pressure and the angle of his is becoming very acute. So now the preference is for left lateral, and the Cloherty, now the latest edition is not mentioning right lateral or left lateral. So that is for your information. Now I move on to a bottle-fed newborn baby is having blood in stool, no fever, sepsis screen is negative. So most of us will be thinking of, what are we thinking of? Cow's milk protein allergy, no? So cow's milk protein allergy, and the food reactions can be immune mediated or non-immune mediated. The immune mediated can be IgE mediated. If it is IgE mediated, they will usually have urticaria, and non-IgE mediated will be the enteropathy. This child with blood, even IgE is not going to help you. And both mixed will be the eosinophilic esophagitis. I think there is a talk on that. And there can be allergic contact dermatitis, cell-mediated also. And non-immune can be because of lactose intolerance, hypersensitivity to some of the components, toxins, food phobia, etc. So we use different tests. And in rectal biopsy, they say in such children, more than 6 eosinophils per high power field is said to be diagnostic of the cow's milk protein enteropathy. But for us, a clinician, what is important is elimination diet and re-challenge remains the gold standard. We have to stop all animal milk and milk product. And then including soya milk, we won't give in a baby less than 6 months. Previously, we used to jump with the soya milk. One reason is that there will be cross allergy. So if cow's milk protein allergy is there, there will be cross allergy even with goat's milk, etc. And soya protein also, there can be cross allergy. And now we understand that the soya has got plant estrogens. And we do not know the effect of plant estrogen getting, acting on a growing genitourinary tract of the baby. So we are, after 6 months, if the baby needs a supplement, we may be going for soya milk. And there are, the allergens are egg, milk, tree nut, peanut, wheat, etc. And which is going to last and which are going to come off. And we can see that the egg allergy and the milk allergy will be gone. Almost to 99% will be gone by school entry. Earlier the onset, a newborn is having blood, that means they may get over it by 1 year. If it is late onset, they may take some more time. But this, the peanut and the fish allergy is going to continue lifelong. And previously we used to say that let us postpone because there is chance of allergy. Now the theory has changed. Cutaneously, if they get sensitized, they go to asthma allergy or all those allergy, that is the Th2 pathway gets activated. But if oral challenge is given, they go to Th regulation and get tolerance. So now the theory is that mother should not restrict, because my first child had milk allergy, so I'm going to restrict during pregnancy. That is gone. And then at the right time, you introduce the egg and milk, everything to the child. And because postponing is not the answer, an early oral challenge leads to tolerance. That is the latest theory. But how early can you introduce? They say after 4 months, but it is better to wait for 6 months because there is a leaky gut. And when there is a leaky gut, they may not split it up into amino acids. They may absorb it as a peptide and get sensitized. So that is the final word about it. And now a child is coming with watery diarrhea following an acute episode. perianal excoriation, malnourished. Of course, all of us are thinking of lactose intolerance, and malnourished baby may not repair the epithelium so fast. Once the epithelium is repaired, the disaccharidases will come back. But in acute diarrhea, a baby who is breastfed, if you check the stool, there will be some sugar because it is lactose load and there is intestinal hurry. So don't check for any lactose intolerance, etc., pH and sugar, etc., for a baby who is having diarrhea less than 2 weeks. If it is more than 2 weeks only, you will have to do. And what is the diet? So initially we will go for low lactose diet. Then 1 week there is no response, we may go for lactose and sucrose free diet. And third, we may go for the monosaccharide diet. And sometimes we may go for elemental diarrhea. That is, we restrict the total milk to 50 ml per kg per day and don't give it as a milk feed. It has to be given with a cereal, like a rice kanji or with milk. So add it to some cereal and then make a porridge and give it. That is the first thing. And in the second one, we are doing away with whole lactose. So egg white and chicken puree will be your protein and glucose will be your carb. It is not sugar. And then monosaccharide, again, this is the diet we propose. And we have to supplement the zinc, the ORS, vitamin A, folic acid, etc. And here I would, because some postgraduates are here, what is the zodiac of diarrhea? The zodiac of diarrhea is zinc. Zinc has got numerous benefits. Due to lack of time, I am not going to go into it. Give zinc for 14 days, ORS, D is for diet. And I, immunization, lot of immunizations, which we generally not consider, even influenza, measles, all are effective against diarrhea apart from the rotavirus. Then antibiotics judiciously. Don't meddle with the flora. That is the first thing. Let the milieu be there. And if you give antibiotics, the normal microflora will be damaged and there will be overgrowth of resistant bacteria. That is the thing. And C is for cleanliness. Okay. And an infant is having jaundice, clay-colored stool, and high-colored urine. So what is your thought? Neonatal cholestasis. And here we are restricting the fat, but we have to give MCT. MCT is medium-chain triglyceride, which will be absorbed directly into the portal vein. And a common thing which is very famous in South India is the coconut oil. The cottonseed oil, MCT powder, etc. we can give. And then fat-soluble vitamins should be given 5 times the normal per day. And water-soluble vitamins will be given 2 times the normal. So we have to calculate and give to a child with cholestasis. Now a child with renal failure and growth failure is coming, and here the important thing is how to restrict the sodium. So no table salt or seasoning with salt. Then snacks such as chips, salted crackers, nuts, salted cheese, butter. Cheese, butter mostly we get salted, canned soups, salted meats, and even the monosodium glutamate, which is commonly known as the Ajinomoto. So eating out will not be good for such children. And the next thing is how to reduce the potassium. We say all fruits, nuts, chocolate, and what you can do is that some vegetable you want to give, slice it, rinse it, put it in warm water, and or double boil. So first you boil the vegetable, then pour off the water, then again you finally cook. So that is it. And here I want to tell you, when children are sick, always people have a tendency, especially in South India, to give coconut water, isn't it? The tender coconut water. See there, what is the sodium? 105 milligram. What is the potassium? 250. So 2.5 times more potassium is there. So this is not a ORT also, because the sodium is low and the potassium is too much. So that is something I want to stress. And phosphate restriction, because hyperphosphatemic renal rickets, etc., we get in CKD, and all protein-rich food is a phosphate-rich food also. So restricting the protein-rich food, then non-vegetarian, and that is it. So now we leave to another child who has failure to thrive, malabsorption, pallor, following introduction of complementary feeding. What are you thinking of? Celiac, very good. Celiac, so we always say wheat, barley, rye, and oats. Actually, oats doesn't have the gluten, but commercially prepared oat has got contamination. So because of contamination, commercially prepared oats also we don't recommend, but theoretically oats does not contain the gluten. And they can have all fruits, dry fruits, vegetables, non-vegetarian food, milk products, pulses, cereals, etc. And here I want you to know about some hidden gluten. That is rava, suji, maida. Many mothers may not know that the suji and the rava is coming from wheat. So they may, it looks white also, no, they may not know. So we have to tell them, give them biscuits, bread, cakes, pastries, noodles, malted drinks, ice creams, ready-to-eat soups. So this we have to specifically tell them when they are on a gluten-free diet. And tetra pack of curd, hinge, that is asafoetida, honey, ice cream, ketchup, edible gums, lipsticks, etc. So these are some list that we give them. And there should be a separate set of utensils, plates, and even a different mixer for the child, because there will be cross-contamination when we are using the same mixer. And see, one child, see, pre-gluten-free diet and the 1 month after gluten-free diet. So such changes you will see when you restrict the gluten. But now many people are simply telling that I am gluten sensitive. It has become a fashion, like autism. My child, my Mendel's abnormality also, they come and say, oh, my child is autism. And they put the child in autism school. And what is happening? The real autism kids' opportunity is getting affected by all the mentally abnormal children are getting put to the telling that my child has autism, my child has autism. So this is it. Now I take you to another scenario: vomiting, developmental delay, cataract, hepatosplenomegaly, mild icterus. Breastfed baby, what is it? Galactosemia, okay. And here there is an interesting story that the mother said, tolerates Newsobi Zerolac but not Soyal and Pro-Soyal. So we were researching what is happening. Actually, include soy protein, avoid whole soya. So whole soya preparation may have the galactose. So soy protein extract, so the preparation also counts. And they can take everything other than milk and milk products, and even the whole soya they cannot take. And organ meat should be avoided, butter, ghee, baked food, etc. Now, when it comes to inborn errors of metabolism, we have dietary management, enzyme replacement, and cofactor therapy. I am not speaking about the genetic enzyme replacement. I am only speaking about what is lacking on the dietary side, what we can do. So, depending on the diagnosis, the companies have produced the specific formulas. So, we can prescribe a formula, but the availability is less and the cost is so much that they cannot afford. But nowadays people have relatives in Canada, US and all, and they are bringing giving them all these things. Now another story is a child with chronic respiratory symptoms, failure to thrive, malabsorption. What do you think? Cystic fibrosis. So here what is possible is a PERT. That is pancreatic enzyme replacement therapy. And the Creon and all is available as a capsule. And we have to give, that is per feed 1000 lipase units. So there is lipase, protease, etc., but the dose is calculated according to the lipase. But how do we give the tablet? And you know it erodes. You cannot just give it into the mouth, it erodes. If it is a complementary food, we can mix it with that. But with milk and all, how to give it? It is a big challenge for us. And Now I'm happy to say that Abbott has come out with a Creon SD. See, that is a special bottle, and they invert it and put a puff, and that puff, one puff will give that liquid will come like that. Then we can add on. But the tablet is very difficult because it is coming in 25,000, 10,000. Our child may need 3,000. So how to take it? And we cannot just do it. So that is a challenge that we are facing. And another interesting area is the cofactor multivitamin or cofactor therapy. For example, in mitochondrial disorders, thiamine responsive, MSUD, we can give thiamine. In glutaric acid, we can give riboflavin. Pyridoxine can be given in oxalureas and homocystinuria. Cobalamin in methylmalonic acidemia and homocystinuria. Folinic acid in orotic acid urea, and biotidinase, biotin, carnitin in MSUD, and most of the organic acidemia. So this is something which we can manipulate, which is within our hands. I think now I come to the last scenario, that is intractable epilepsy. People are thinking of nutritional ketogenic diet. I'll say for a pediatrician or a medical person, we should not speak of ketogenic diet. Ketogenic diet is being done by every Tom, Dick and Harry, and what they are doing, they also don't know. What we are doing is nutritional ketosis. Under supervision, we are inducing ketosis, and it is not ketogenic diet. We are inducing, that is called nutritional ketosis. And there is one group of conditions where there is cerebral creatine deficiency syndromes, and there also there is a scope for therapy, and all myoclonic or resistant epilepsies are not going to be responding to our diet. What is going to respond is the glucose transporters 1. So genetic. Now genetic study is done. Even in HIE, if it's resistant convulsion, they do, and they find that the child is having a genetic syndrome. So genetic syndromes, genetic study we have to do, and select our patients for the nutritional ketosis. And cofactor therapy, I already said, and in creatine supplementation is being done in the cerebral creatine deficiency. So for success, what we have to do is we have to build the team. And the team means together everyone will achieve more. And our dietitians, nurses, parents, everybody should come together. We should have a discussion, and we should build our team. That is it. And who is this? Who is this Rishi who is holding the Amrita? Dhanvantari, the god of Ayurveda. He says, even in excess, Amrita is a poison. So we have to see that these are all double-edged sword. Thank you very much for this opportunity. Thank you for patient listening.
Thank you so much, madam. Such an important topic. We are very happy to learn from you so many things. We have two eminent speakers. I'm sure that we are going to have a lot of queries. The floor is open for discussion. If you have any queries.
Yeah, MSUD we don't give. Galactosemia we don't give. We can give. That is, the cofactor is B12. And if it is B12 related, both methylmalonic acid as well as homocysteine will be high. Whereas if it is folic acid related, only homocysteine will be high.
In our institute, we commonly prefer IV labetalol as the first choice. Sir. We use esmolol. We don't use sotalol. Sotalol is mainly used as an antiarrhythmic. It won't be used as an antihypertensive, sir. So esmolol we use if it is post-operative hypertension. Post-operative hypertension, if the hypertensive crisis is due to coarctation of aorta, or as I said, it is catecholamine-driven hypertension. For example, pheochromocytoma, we have controlled the BP with alpha blocker initially. Then during intraoperatively, if the child develops hypertension, that time we have to use beta blocker. In those conditions only we prefer esmolol. Otherwise, commonly we prefer labetalol as the first choice, provided there should not be any myocardial dysfunction. If there is a already pre-existing cardiac failure, the labetalol may worsen that cardiac failure. In those conditions, we go for vasodilators like sodium nitroprusside or hydralazine. So commonly we use labetalol or sodium nitroprusside.
Suppose I am practicing in the periphery, I pick up high BP, but I am not able to secure an IV line, I am not sure of the doses. I just want to give some antihypertensives and shift the child. There used to be, as a postgraduate, I have given numerous doses of sublingual nifedipine because before it became unpopular. Can you clarify?
Sir, sublingual, as I said, sublingual is associated with very rapid reduction in BP when compared to oral nifedipine. But that was proven in adult age group. Even studies, lot of studies which have proven that in adults, when you give sublingual or even oral nifedipine, it will cause rapid reduction in BP, so it is contraindicated in hypertensive emergencies. Whereas in pediatric age group, there is no, there is head-to-head trial or literature available, but when I retrospectively reviewed, most of the studies have shown that even when they have used nifedipine in pediatric hypertension, there was not much rapid reduction in BP, or there is no development of any end organ damage symptoms. So in pediatric hypertensive urgency, nifedipine can be safely used, but at any point of time, oral nifedipine is more preferable than sublingual nifedipine.
Are there any more queries through WhatsApp or anything? I think if there are no more queries, I think we'll close this session. We'll move on to the next session. I thank both the speakers.
Thank you, sir. Thank you, thank you, dear chairperson and speakers. I now request our chairperson, Dr. Babu, to kindly hand over the mementos to our distinguished speakers, Dr. Elizabeth ma'am and Dr. Muthuvel. Thank you, sir. I request Elizabeth ma'am to hand over the memento to our chairperson, Dr. Babu. Thank you, sir. Thank you, dear speakers and chairperson. So next will be the general body meeting in Sirwani Hall, and we'll be back in Hall B at 4 p.m. with the next session. So thank you. See you all at 4 p.m. sharp.